the organizing team for a fantastic time here and very good academic sessions. So just we heard from Professor Das that burden of diabetes is increasing in India. And what do you mean by burden? Burden is not only numbers. It's actually the burden, so that there are more deaths because of the disease. There is more economic burden. So the India comes into a country where that not only the number is more, there is a huge burden, expenditure, healthcare expenditure, morbidity and mortality is much higher in our country, and so we need to get tuned to it. We are quite trained in the conferences to see the patients and have specific goals. So we are so much involved in the patient who is sitting in front of us to have a correct and proper treatment. Sometimes we need to come out of that and have a bird's eye view of the society and look at the points which can be missed if you are only involved with one patient. And here comes the role of, how the patients are taking these medicines or how they are following your advice, which we are sitting and giving. So we know the goals. We need early and aggressive A1C control without hypoglycemia, without any weight gain or maybe weight loss we need in patients. We need to focus on glycemic variability when we are managing this juggling of A1C, avoiding hypoglycemia. Also, we need to have whole vascular tree protected. It's not cardiovascular risk, brain, everywhere, peripheral vascular disease, kidney, liver. While doing all this, I think one of the goals we should make is also of the adherence. So if the adherence comes into the goal of our management, not only to improve other goals, but itself it should be a goal when we are practicing. And let's have some information which I will like to share with you about how adherence changes with different patterns of treatment. I think long back, 20, 30 years back when we started giving talks, there used to be a triangle: diet, exercise and medicines to treat type 2 diabetes. Some of you might remember that. So these are the major pillars of type 2 diabetes management. Then came the evaluation, tests, and of course monitoring glucose as well as other monitoring. And all these pillars are based on adherence, so which is the major base of all the peers. There is no adherence, there is no lifestyle change, not only taking pills or insulin. So adherence should be a goal, and if the adherence is suboptimal, it increases complications. We know that all microvascular major adverse events will go up if patients are not adherent to whatever you are saying or whatever you are prescribing. It will increase mortality, as I was saying, burden will be more, increase hospitalization and increase health expenditure. So that is the issues if patients are not adherent. There are barriers to the adherence. So most common is forgetfulness. Every day you have to take tablets, so many tablets. So sometimes they want to cheat a day or they want to take time off and patients don't take. So forgetfulness, cost, I will come to that, but the cost of the therapy is a major determinant of adherence. Side effects, if they are not properly explained, mainly hypoglycemia. So many of our patients come to us because someone prescribed me something, but I had a bad hypoglycemia. Then I stopped everything. A1C jumped to more than 10, and then the patient changes the doctor and comes to you. So we should avoid, especially in newly diagnosed diabetes, whether it is severe hypoglycemia, even a simple relative hypoglycemia, one need to be aware and need to avoid to improve the adherence. Low perception of complications. Patients are very hale and hearty, having a good life, they are enjoying life, they are fit, doing exercise, they are not aware of complications, we see them. And they don't want to talk about complications. Howsoever you know that important it is, they are interested in their daily life. When they will go out of this clinic, next appointment is waiting for them for some other work, take the prescription and run out of the clinic. So these are the people, they are not aware of the complication. That itself decreases the adherence, whatever you are telling them. So I think low perception of complication is again important. This was the effect of cost on adherence prescription done by Canadian healthcare studies, and you can see that more people are adherent, there is a less of the expenditure, more of the saving, especially in chronic diseases of heart failure, hypertension and diabetes. So adherent definitely reduces the cost expenditure. There is one study done, though the country is Ethiopia, you can see it's a clinic-based study, outpatient department, and there are about more than 400 samples where the adherence was related to the how the patient's HbA1c is controlled or not. Here it was more than 77% were not adherent. So it was quite a bit that they are not adherent, but I think any clinic, it's 50%. When you think of adherence, we see patients in our clinic who are coming to us regularly. We don't think patients who are not visiting you regularly, and there are so many patients who are not visiting anyone regularly. So the perception of adherence in our minds also need to be changed by proper seeing the statistics. So this actually study showed that the responsible factors for poor adherence was medication cost. You can see the p-value. Monthly income, the poorer patients have less adherent. Self-monitoring of blood glucose improves adherence. So done in a structured way, it will improve adherence. Number of medications, big prescriptions, adherence goes down. It has significant relation. And comorbid condition, of course, there is a relation with the adherence. So this was a clinic-based study. This was a nice meta-analysis just published in February 2023. There are more than 156 studies, you can say more than 10 million patients are here. And there is a systemic review and meta-analysis which studied the adherent, what are the different patterns of adherence, what is affecting. And what it showed a significant association between good glycemic control and a good adherence. So someone is adherent, the A1C is better. This meta-analysis also showed that adherence to OADs in type 2 diabetes is suboptimal. You can see almost, I think 50%, 54% of patients were adherent, but almost 50% were not adherent. So one of the goals should be having a therapeutic adherence. So we should include this adherence in our goals to design a proper prescription. Therapeutic adherence is different between different oral agents, and which has seen in many kind of studies has been published, but this meta-analysis again shows that adherence was poorest with metformin and alpha glucosidase inhibitor because of the GI intolerance we know. But best was with thiazolidinediones. You can see 68% because we all remember the rosiglitazone days. The patient came to us after 6-7 years when the drug was banned. They were taking the tablets, whatever stocks were available with fantastic A1C, and then they came, now this drug is not available. So we know that adherence, but DPP-4 inhibitors and SGLT2 inhibitors have a better adherence compared to sulfonylureas or insulin secretagogues. So it changes the complex prescriptions like one insulin and 3-4 drugs, different complex insulin regimens, the adherence goes down, which we all know. Polypharmacy versus monotherapy, we know that sometimes too many drugs in one pill. As a treating expert doctor, you may not be confident because it may change pharmacodynamics sometimes by having too many drugs in one pill. And you don't get that, fine tuning of the patient's glucose if I'm using combinations. So many of us don't like these combinations to use, but number of drugs, polypharmacy will decrease the adherence. So whether you like it or you don't like it, decreased number of pills, combination pills will improve adherence. This is very important. What they found out that in younger patient, there is a poor adherence. As I was saying, very busy people, and this is alarming. So our approach to young patients who are working should be completely different, and we have to have some age-wise specification in our clinics, whatever digital technology we are using to improve adherence and focus on younger patients. Older patients are more adherent, and there was no difference between men and women in this meta-analysis about adherence. The cost of the drugs, I think it's very important that we know that cost actually decreases because of, it's not only in India, we are very cost sensitive people. We have a big Apple store now in here, it's manufactured in India, everyone uses iPhone, people fly business class, but when it comes to health expenditure from their own pocket, they don't want costly drugs, which we all have experienced. So it's not only for poor people, but even for the rich people. India is a cost sensitive country, so low cost drugs will definitely improve adherence in all our patients, which we have experienced. This fight we know, Indian generic drug firms with pharma multinational companies about the cost of medicines. And every day we are going through this, we are reading a lot of articles. So patent rights versus patient rights. When you look, it's not only these fights. between the pharma companies, but when you have a wider picture, a very costly drugs which is so effective to improve complications, if the cost is reduced, is it not patient's right to use that drug at a low cost rather than fighting for patents? So before the SGLT2 inhibitors became out of patent, this was a WHO study which is called as MPP licensing, that before the drug goes out of patent, if it is available as a low cost, there was a good paper here, and what it shows that if you make these drugs available, it was the focus on DPP4 and SGLT2 inhibitor before, this was some few years back, and what it showed that access is improved, so many patients can get these medicines, it delivers so many million patient years of life, it can avoid so many cases of major adverse cardiovascular events and additional good quality of life if the drugs are made available at low cost before the patent gets expired. That was the MPP licensing. And these calculations are only cardiovascular benefit, but there are additional benefit of delaying kidney disease, delaying vision loss, avoiding severe hypo, weight loss is there, delaying insulin treatment. These are indirect wider benefits of making these drugs. So there is no legal battles will go on, but if you see sometimes we know that patient rights takes over the patent rights, and sometimes we need to accept these low cost drugs which will access like SGLT2 inhibitors. Now they are accessible to each and every of our patients, so maybe the benefits are much more. Structured monitoring of blood glucose should be used in a very correct way to improve adherence. It not only improves HbA1c, it improves patients' adherence to drugs, to insulin treatment, their lifestyle, what they are eating, how much they are exercising. If it is done in a structured way, by using technology, by using apps or different kind of software tools, digital technology, we can use structured self-monitoring. CGM is there, no doubt, but you can't use it for each and every patient. But structured self-monitoring can be used for every patient, which will have an improved disease awareness. Patient feels participated in his treatment, he takes active control of the disease, and there is an improved ability to recognize not only hypoglycemia, but also his or her behavior patterns. And there is an improved adherence to drugs, diet, exercise. So structured SMBG should be used as a good tool with digital technology to improve adherence in our patients. So as I said, diabetes education, continuous education is important to patients. Age-wise different approach is important to improve adherence. We need to focus on a younger patient, as we see so many young patients below age of 40, below 45 who are struggling with diabetes with 4 medicines on that with their full life going on. Hypoglycemia, we needs to avoid not only severe but even a simple relative hypoglycemia can decrease adherence. Discuss side effects with the patient, make the patients aware so that they will not stop eating, but they will see it, in a proper way. Okay, these things may happen. There will not be a kind of misconceptions or myth about the drugs. Choice of drugs, as I was mentioning, you should know that which will have a better number of drugs, though whether you like it or you don't like it. Combination pills are going to improve the adherence. Different mobile apps, there are papers, because the apps are so different, you will not get a good papers which is showing, but perfect apps which are using these technologies, which can again change structure according to the patient's need, will definitely improve adherence as technology, as I was saying. So assume that every patient is going to be non-adherent, and then try to set up the goals and your prescription. Developing a trusting relationship with the patient is also improves adherence. So like as you become senior, your patients are there for so many years, they don't ask you questions. You write insulin, they will take insulin. No, I am telling you, I don't want to talk. I am telling you, you need insulin. They don't ask you second question. So one thing is good, as you become senior, the patients are more adherent, they accept your thing. But a trusting relationship is very important, and a better communication, which I feel in our medical education, these things lack. No one teaches us about communication, no one teaches us, but we are only focused on the medical knowledge. And I think if the medical schools become like IIT schools, I think the doctors will also be all over the world doing so many better things, and the technology people will not overpower us. So I think our medical education system need to be changed, and we should include everything here which we always talk and say this is less. So effective use of technology is there. So as I was always, we know that one size fits all approach is not there now, and we know that it has to be individualized. Every patient we need to see that how I can improve adherence in this particular patient, then all my pool of patients, all my younger patients. So we need to change your approach in the clinic, and a lot of other associations, and also at the government level. Trust is a critical factor in an effective relationship. If you are a competent doctor, but if you are very low in competence and low in caring, it will create a distrust between the patient and the doctor. If you are very competent, but if you are not caring, you are not having a good communication, you are not talking, the old days are gone. The doctor is very rude, but he is very good. Those days are gone. You need to be sweet, you need to be better in communication, you need to be competent. But if you're not caring, there will be a respect, but patient will not follow you. They will say, oh, he's a very great doctor, but no, it's okay, I will go to my doctor. So only competence doesn't enough. If you are more caring, but if you are not competent, there is an affection. Patient will say, oh, he's a good doctor, she's a good doctor, but she's not great doctor or not a correct doctor. So you need both. You need a very competence by attending such meetings, having updating knowledge every week for ourselves, and also being very caring for the patient and having a very good communication. Then the trust develops, and actually the adherence can be improved. So thank you so much. And I really thank Dr. Vijayakumar, GVK known in this part of the world, and for having this topic to remind all of us that we are really forgetting this very important topic of adherence. So thank you so much.